all. This video is on the functions of basal ganglia as well as Parkinson's disease. Functions of basal ganglia. The main function is that planning and programming of movement. So, it includes processes by which an abstract thought it is converted into a voluntary action. That is, it is found that the neurons of the striatum of the basal ganglia it begin to discharge before the movement occurs, and this sequence, that is the neurons of the striatum discharging prior to the movement, suggests that these neurons help to select the movement that is to be made. Second function of the basal ganglia is to plan and control complex learned patterns of motor activity, and this is with the help of the putamen circuit. We all know from the childhood itself how to cut the scissors, also how to hammer the nails. So, this type of learned patterns, that is whichever motor activity we have learned in the early childhood itself, the planning and controlling of these complex learned patterns, it is also another function of the basal ganglia, and this occurs with the help of putamen circuit. And the examples for activities are like cutting papers with scissors, hammering nails, writing of the letters of the alphabets, shooting basketball through a hoop. Then most aspects of vocalization as well as controlled movements of the eye, and we all know that we are performing most of these actions subconsciously, and this is with the help of the putamen circuit. Now we will see what is this putamen circuit. The premotor as well as the supplementary areas of the motor cortex and also the somatosensory areas of the sensory cortex, they send the fibers to the putamen and bypassing the caudate nucleus. You know that striatum has two parts, that is caudate nucleus as well as putamen, but here the fibers from the premotor as well as supplementary areas of the motor cortex and the somatosensory areas of the sensory cortex, they send fibers only to the putamen portion, and from the putamen the fibers are sent to the internal segment of the globus pallidus, and from there the inhibitory fibers are moving into the ventro-anterior as well as the ventrolateral nuclei of the thalamus, again sending the fibers back to the cortex, forming the cortical, the cortico-basal ganglia, thalamus cortical loop. And functioning in close association with this primary putamen circuit are certain ancillary circuits. Here, the fibers from the putamen, instead of going directly into the internal segment of the globus pallidus, it passes through the external segment of the globus pallidum, subthalamus, substantia nigra, and finally returning to the motor cortex by the way of thalamus. Next function of the basal ganglia is the cognitive control of the sequence of motor patterns, and this occurs with the help of the caudate circuit. First of all, we will see what is this cognition. Cognition means it is the thinking process of the brain using both sensory input to the brain along with the information which is already stored in the memory. So, the cognitive control of the motor activity is determined subconsciously as well as within seconds patterns of movements to be used together to achieve a complex goal. We will see what more about the caudate circuit. You all know that caudate nucleus extends to almost all lobes of the cerebrum. That is, anteriorly the caudate nucleus got extension into the frontal lobe, posteriorly into the parietal as well as the occipital lobes, and curving forward like a C into the temporal lobes. And it receives the input from the association areas of the cerebral cortex overlying the caudate nucleus. So, the caudate circuit includes the fibers from the caudate nucleus, sending directly the fibers to the internal segment of the globus pallidum, from there into ventro-anterior as well as ventrolateral nuclei of the thalamus, and from the thalamus, the fibers pass through the association areas of the cerebral cortex, finally into the cerebral cortex. So the same thing, that is the fibers from the cerebral cortex, it reaches the caudate nucleus, and from the caudate nucleus the fibers are going into the internal segment of the globus pallidum, and from there into the thalamus, and from the thalamus back into the association areas of the cerebral cortex. So, example of cognitive control of movement are that if a person sees a lion approaching, he will respond instantaneously as well as automatically. That is, first he have to turn away from the lion, then he have to begin to run and even attempting to climb a tree. So, this planning occurs because of the basal ganglia. Next is the change the timing as well as to scale the intensity of movements. That is how rapidly the movement to be performed as well as how large the movement will be. So the basal ganglia in close association with the posterior parietal cortex helps to change the timing as well as to scale the intensity of the movements. Next function of basal ganglia is to control the automatic associated movements. That is, while walking, we usually swing our hands, and this occurs almost subconsciously. So, this automatic associated movements are also controlled by the basal ganglia. And another example for this is display of the emotions through the facial expressions. Moving on to the next function, that is maintenance of the background posture for different voluntary activities. That is, even if you bend down and took something from the ground, the basic posture of the axial and the proximal muscles is controlled. That is, maintenance of the background posture for different voluntary activities. It is also the function of the basal ganglia. That is, basal ganglia being a part of the extrapyramidal system, it influences the activity of the medial descending order systems and control the axial as well as the proximal muscles. Next function is that it helps to maintain the muscle tone. That is, it will cause an inhibition in the gamma motor neuron discharge as well as it will cause an inhibition of the stretch reflex. Normally, the basal ganglia is inhibitory to muscle tone. That is, it will decreases the muscle tone. So, what happens in lesions of basal ganglia? The patient will present with hypertonia. And the other functions are, it will facilitate the desired movements, it will also inhibit the tremors as well as the involuntary movements, and the head of the left caudate nucleus, it is concerned with the speech of a person. Next, about the common clinical disorders. Mostly lesions of the basal ganglia produces two type of disorders, that is both hyperkinetic as well as hypokinetic disorders are produced. In hyperkinetic means movement will be excessive as well as abnormal, whereas in hypokinetic the movement will be less as well as abnormal. And the examples of hyperkinetic movements are chorea, athetosis as well as balism, whereas hypokinetic movements include akinesia as well as bradykinesia. So this can be asked as an MCQ question. Examples for hyperkinetic as well as examples for hypokinetic movements. Again, MCQ portions can come from this part of the video also. That is chorea. It is another feature of basal ganglia lesions. That is, it is characterized by rapid involuntary dancing type of movements will be produced in the patients. And here the lesions occurs in the putamen. So please keep in mind that putamen lesions lead to the chorea. The next abnormality is the athetosis. That is, the patient will give a continuous slow writhing type of movements, and the lesion occurs in the globus pallidus. So, globus pallidus lesions give rise to the abnormality, that is athetosis. Next is hemibalismus as well as balism. It is involuntary flailing type of intense as well as violent movements, and here the lesion occurs in the subthalamus. Next is echinacea, that is difficulty in initiating a movement because of the decreased spontaneous movement is the. Next is bradykinesia, which is characterized by slowness of the movement. And please keep in mind that here in all basal ganglia lesions, the motor dysfunction is always contralateral to the disease component in all basal ganglia disorders. That is, if left basal ganglia, left nuclei is affected, then right side of the body will be affected. So that is about the clinical disorders in general. Now we are moving on to the Parkinson's disease. Another name for Parkinson's disease is paralysis agitans, and it is one of the most common neurodegenerative disorders, and it is more common in males when compared to that of females, having a ratio of 1.5 is to 1. And the main pathology is that there occurs degeneration of the dopaminergic neurons in the pars compacta region of the substantia nigra. And these dopaminergic neurons as well as receptors are steadily lost with the age. And what are the etiology for this Parkinson's disease? Mostly it is sporadic idiopathic in elderly individuals. In some cases it can be familial, and it can also be produced by drugs like phenothiazine, which is an example for tranquilizer, and D2 receptor blockers. And another cause for this is the MPTP injection, that is 1-methyl 4-phenyl 1,2,5,6 tetrahydropyridine. This MPTP, it is a prodrug that is metabolized in the astrocytes by an enzyme which is known as the monoamino oxidase B to produce a potent oxidant, that is 1-methyl 4-phenyl pyridine, that is MPP plus, which will be taken up by the dopamine transporter into the dopaminergic neurons in the substantia nigra, where it destroys the dopamine. And here the symptoms usually appear only when 60 to 80% of these dopaminergic neurons are lost, and the patient will present with both hypokinetic as well as the hyperkinetic features. And the main clinical features include rigidity, that is both lead pipe as well as cogwheel type of rigidity are seen in Parkinson's disease. Next feature is the resting tremor, that is tremor got a frequency of 8 heads of contractions of the antagonistic muscles. Akinesia is another feature, that is difficulty in initiating the movement. Then postural instability, that is there will be impaired postural reflexes. And other features of Parkinson's disease include dysphagia, speech disorders, gait disturbances as well as fatigue. Now about the physiological basis of the symptoms in Parkinson's disease. You all know that in normal individuals, the basal ganglia discharge is basically inhibitory because of the presence of the neurotransmitter GABA. And these dopaminergic neurons from the pars compacta region of the substantia nigra to the putamen, they have mainly two effects. That is, this dopamine will bind to the D1 receptors and it will cause stimulation of the D1 receptors. And this will inhibit the internal segment of the GPI, which produces usually the GABA. And the dopaminergic neurons also inhibit the D2 receptors, and this D2 receptor inhibition also will produce inhibition of the internal segment of the globus pallidum. And what happens when the inhibition of the putamen happens? This inhibition will reduce the excitatory discharge from the subthalamic nucleus to the globus pallidus internal segment. So there occurs a balance between the inhibition as well as excitation for maintaining a normal motor function. Now, what happens in Parkinson's disease? This connection from the substantia nigra pars compacta into the putamen is lost. That is, the dopaminergic input to the putamen will be lost. So there will be decrease in the inhibition as well as increase in the excitation of the subthalamic nucleus to the globus pallidus internal segment. So overall, there will be an increase in the inhibitory output to the thalamus as well as the brainstem, which will produce disorganized movement. Next, about the treatment of Parkinson's disease. It includes both medical treatment as well as surgical treatment. The medical treatment include giving the drug L-DOPA or levodopa. This dopamine precursor crosses the blood-brain barrier and it is converted in the brain into the dopamine, and it will restore the normal balance between the inhibition and excitation. And this mainly helps to ameliorate the symptoms like rigidity as well as akinesia. Next is Cinemet. that is a combination of L-DOPA plus carbidopa, and this one is the most commonly used drug in case of Parkinson's disease. And addition of the carbidopa will increases the effectiveness of the drugs, and this will actually prevent the peripheral conversion of the L-DOPA into dopamine. So it also causes a reduction in the adverse effects of the L-DOPA. Dopamine agonists include apomorphine, bromocriptine, pramipexole as well as ropinirole, which will act directly on the dopamine receptors and act like the dopamine itself. Next are certain anticholinergic drugs which will decrease the cholinergic influence. Then catechol-O-methyl transferase inhibitors, that is endacapone, which will block the breakdown of L-DOPA. Then monoamino oxidase B inhibitors like serigilin as well as L-diprenate, which will block the breakdown of the dopamine. Next is about the surgical treatment. It includes pallidotomy, that is artificially producing lesions in the internal segment of the globus pallidus for reducing the inhibition. Then thalamotomy, that is subthalamic nucleus will be resected. Then implant dopamine secreting tissue. Implant dopamine secreting tissue in or near the basal ganglia, especially from the adrenal medulla as well as the carotid body. Then the transplantation of the fetal striatal tissue, deep brain stimulation as well as local injection of the glial cell line derived neurotropic factor GDNF attached to the lentivirus factor. So this first two, that is pallidotomy as well as the thalamotomy, it helps to restore the output balance towards normal. Whereas the deep brain stimulation, it reduces the tremors, slowness of the movements and gait problems, and produces temporary disruption of the circuits at the electrode tip on demand and simulates the effects of lesion. So that is about the functions of the basal ganglia as well as the Parkinson's disease.